Hello, my name is Katerina Vaporidi, and this presentation is about a practical approach to patient ventilator asynchronies. These are my conflicts of interest. Asynchronies is a mismatch between the neural and the mechanical timing of the breath. In a broader sense, though, there is a mismatch between the assist provided by the ventilator and the patient demands. Let's start with some definitions. In the right panel here, you can see the waveforms of transdiaphragmatic pressure, flow, and airway pressure in a patient ventilated in pressure support mode. The blue arrow indicates the neural inspiratory time, which is the time of the respiratory muscle contraction. The mechanical TI is the time of the delivery of positive pressure, highlighted blue here and identified in the airway pressure waveform. Let's start with asynchronies occurring at the beginning of the breath. These include triggering delay, auto-triggering, and ineffective efforts. Triggering delay is a kind of inevitable asynchrony. It's the interval between the beginning of the inspiratory muscle contraction and the delivery of positive pressure by the ventilator. Obviously, as the ventilator needs to understand that the patient effort has begun, there will be some delay in this procedure. Triggering delay depends on patient effort, the presence of intrinsic PEEP, the triggering threshold that we have set, and the valve response time, so something of the manufacturer of the ventilator. Bench studies indicate that triggering delay of the current ventilators we currently use in our ICUs are between 50 and 100 milliseconds. Clinical studies, though, indicate that this time interval may be more, about 100 to 200 milliseconds. The neurally adjusted ventilatory assist, a mode where the ventilator is triggered by the electrical activity of the diaphragm, also reports a triggering delay time of about 100 milliseconds. Prolonged triggering delay may result in us measuring a relatively weak patient effort because a large part of this effort has been consumed during triggering of the ventilator. This is why it's important to identify prolonged triggering delays. Another important asynchrony referring to the beginning of the breath are ineffective efforts. In this case, the patient effort does not trigger a ventilator-delivered breath at all. That means that the effort is weaker than that required to trigger the ventilator. You can see on the right panel here, flow, airway pressure, and esophageal pressure waveforms during pressure support again. Highlighted yellow are two ineffective efforts, which can be seen by the distortion of esophageal pressure clearly, but also there is a similar distortion in airway pressure and an upward increase in flow waveform. Ineffective efforts are important because they have been associated with prolonged mechanical ventilation, ICU stay, and increased mortality. It's also important to remember that they occur in clusters, so we need prolonged periods of observation to exclude the presence of ineffective efforts. As said before, the effort that is relatively weak, weaker than that required to trigger the ventilator, is an ineffective one. That means that the effort can be weak per se or relatively weak. An insensitive triggering threshold, which is actually the least common cause of ineffective efforts, can cause this problem. More often, the presence of intrinsic PEEP, where the patients need to overcome it, can cause ineffective efforts. Actually weak efforts can also be the result of weak inspiratory muscles, but also of low respiratory drive. And low respiratory drive means that the patient's brain doesn't want to try, although the muscles could if they did try. Sedation, metabolic alkalosis, or a relatively low PCO2, lower than what the brain demands, can cause low respiratory drive and weak ineffective efforts. The management of ineffective efforts requires discrimination between these two major conditions. And in a case of obstructive disease and the presence of intrinsic PEEP, of course, apart from the disease management, we need to address PEEP and cautiously titrate it to overcome intrinsic PEEP and decrease assist as a means to decrease tidal volume and reduce dynamic hyperinflation. Weak inspiratory efforts, as a result of low respiratory drive, can be managed by interrupting sedation, correcting metabolic alkalosis, and decreasing assist so that the PCO2 will be closer to what the brain demands, and so that the respiratory drive will be restored. The opposite phenomenon of ineffective effort is auto-triggering. Here, the ventilator delivers a breath without the patient inspiratory effort. As you can see here on the panel on the right, with flow airway pressure and transdiaphragmatic pressure during pressure support. Notice that this second breath is not triggered by a patient effort. A very sensitive triggering threshold may promote auto-triggering as a prolonged conditions of zero flow. That means patient has a very low respiratory rate. Decreasing sedation and assist may restore patient's respiratory rate and effort. Strong cardiac oscillations, again in the setting of prolonged zero flow, may trigger the ventilator, as does water in the circuit or leaks that can be managed obviously by fixing this cause. Hiccups is a condition that causes very large swings in esophageal pressure and obviously cannot be managed by modulating the triggering threshold, but require medical management. Another form of asynchrony where the brain has not indicated the start of a breath is entrainment. Here, there is a contraction of the diaphragm without an out-breath delivered by the central nervous system, but as a result of the ventilator-delivered breath. It's a normal phenomenon that has been described in healthy subjects, and it is characterized by a constant temporal relationship between the beginning of the mechanical breath and the start of the contraction of the diaphragm, as you can see here on the panel on the right, indicated by these purple arrows and vertical lines. Entrainment may have important implications. It may prevent diaphragm atrophy as the diaphragm contracts even in the control mode, but it may also promote ventilator lung injury, as in this breath here, where the diaphragmatic contraction causes double triggering and this second breath causes very high distending pressures. Because entrainment occurs predominantly in deeply sedated patients, it is important to discriminate between actual entrainment and spontaneous effort still occurring during a control mode. This can be easily done by placing the patient briefly on CPAP. If the patient presents through entrainment, increasing sedation is the only thing that will not solve the problem. So we have two or actually three options. We can tolerate the phenomenon if it doesn't cause double triggering. We can decrease sedation and use a partially assisted mode, or if for whatever reason it is necessary to maintain a strictly controlled mode to ensure protective ventilation, we may need to use neuromuscular blockers. Moving on to asynchronies occurring towards the end of inspiration. These asynchronies occur with modes where the neural TI is not the sole determinant of the mechanical TI. This occurs in all conventional modes of assist, volume and pressure assist control, SIMV, and also pressure support. It does not happen with proportional modes. When the neural inspiratory time is shorter than the mechanical, we talk about premature cycling off, while when the neural inspiratory time is shorter than the mechanical one, we talk about delayed cycling off. Premature cycling off can be recognized by the shape of airway pressure and flow. As you can see, this distortion occurring, the upward increase of airway pressure and flow occurring immediately or very shortly after the end of the mechanical breath. It is associated for sure with a longer inspiratory effort, but often this implies high drive and strong effort, and a respiratory system with low compliance and short time constant. The implications include the chance of high lung stress caused by double triggering and eccentric diaphragmatic contraction as the diaphragm contracts while lengthening at this later part of the breath. The management may include increasing mechanical inspiratory time, but please note that there is high variability of inspiratory time in spontaneously breathing patients. Increasing assist, again, cautiously, because the patient with strong inspiratory efforts and low compliance is at risk of high lung stress. Management of high respiratory drive, or use of proportional modes. Delayed cycling off, on the other hand, can again be recognized mainly by the shape of flow, where an upward curvature is replaced by a linear or exponential decay, just like it occurs in passive ventilation, and it is often associated with low drive and weak effort and a high time constant of the respiratory system. The implications: a short inspiratory time is common when the effort is weak, and the effort may be weak because the assist is excessive. Please note that the same phenomenon, delayed cycling off, that is, may occur with normal effort and in patients with severely impaired mechanics. The management may include decrease in mechanical TI, again remembering the high variability of inspiratory time, decreasing assist as appropriate, management of low drive whenever present, or use of proportional modes. Another way to classify asynchronies is to focus on the context where they occur. So we have asynchronies associated with high respiratory drive and strong effort, such as premature cycling off that we saw before. And in assist control mode, assist volume control mode, the phenomenon called flow starvation. As on here on the panel below, on the bottom, notice the change of the airway pressure waveform with increasing patient effort. This can be managed with an increase in inspiratory flow or using a decelerating form of inspiratory flow. Asynchronies associated with low respiratory drive and weak efforts include ineffective efforts, periodic breathing, auto-triggering, and delayed cycling off. Here on the panel on the right, there is a case of periodic breathing induced by excessive assist. Please note the gradual decrease of esophageal pressure, the decrease of patient effort. And here in the middle, we have one or maybe two breaths that are auto-triggered. So in this case here, we were not able to detect the apnea caused characterizing the periodic breathing of the patient. These asynchronies are strongly suggestive of excessive assist, and obviously the management would include decreasing assist. To summarize, it is important to recognize and manage asynchronies. Just as these clouds here are not just random clouds, but they indicate an upcoming change in weather, another way to look at asynchronies is as indicators of a phenomenon that is also important apart from asynchronies, that there is excessive or inadequate ventilatory assist. And it is very likely that this underlying cause is associated with the problems occurring during asynchronies, and it is important for us to recognize and addressing the problem of either excessive or inadequate ventilatory assist. And with that, thank you for your attention.
Thank you very much, Dr. Vaporidi, for this very nice presentation. Now there are some questions. Please feel free to ask any question on the chat. I think this is a great opportunity to interact with the experts. So if there is no question, maybe I have one. So Dr. Vaporidi, how to say that? Maybe one of the difficult issue in the field of patient ventilator asynchrony, and that you actually have very well demonstrated in your presentation, is that you need specific skills to detect the asynchrony and additional knowledge and skills to readjust the ventilator in order to deal with the asynchrony. What do you think about the feasibility or possibility that the ventilator can automatically detect asynchrony in order to help the asynchrony detection at the bedside?
Thank you very much for this question. I think this is the most important problem in asynchronies, indeed, that we need better and automated monitoring. Actually, I don't think it's that difficult to identify asynchronies at the bedside, but it is difficult for one physician to be at the bedside 24/7. Usually we take care of about a dozen patients at a time. So obviously we are inadequate in continuously monitoring the ventilator screen. So this is indeed a necessity, the way for technology to go, automated asynchrony detection. Once we are notified of the asynchrony, it is usually easy to fix. So adjusting assist is not really that complicated once we identify the problem. So yes, I fully agree with you. The way to go and the way technology should go is implementing automated algorithms, evaluating, for example, flow shape in the ventilator, so we can have a better detection of asynchronies.